Welcome to Deuk Spine Institute, our live stream of spine surgery today on September 17, 2024. Our first surgery was supposed to be a big one, occipital cervical fusion. We canceled that because we could not get the patient intubated. So we're going to be performing a different procedure on her, and we have a thoracic Deuk plasma rhizotomy. This patient has thoracic facet joint pain. We're going to go in and deaden the pain nerves. He's had over 60 RFAs in his life, radio frequency ablation. I'm going to put some numbing medicine and we'll get started. Little numbing medicine. Now he is sedated with propofol. And propofol is a type of anesthetic that you don't put a tube down the throat. You actually do it through the vein. Patients breathe on their own, sometimes with a little bit of assistance. Incision, I'm going to start on the left side. Our incision is a 4mm incision. With the 4mm incision, we're going to go in and destroy the pain nerves to the joints that are causing pain. Now these joints are called facet joints. And this patient basically contacted me and said, I need you to treat my facet joints. So it's not often that we get patients who can tell you what's wrong with their body, but he's had facet pain for many, many years. And that facet pain has been treated over the years with radio frequency ablation. And he's had multiple radio frequency ablations done. I think he told me somewhere over 60 of them. So, shot. I'm going to aim for T1. T1 is just up there. Shot. Let me just get focused for a moment, Dr. B, and I will answer you. Shot. If you have questions, feel free to ask them. His facet joints don't look particularly angry, as a matter of fact, but we know, at least he does, that that's where the problem is. Shot. All right. So our first target we are sitting on top of, that's T1. And I'm going to perform our first rhizotomy, left T1. We call this the Deuk plasma rhizotomy because it's performed differently than an RFA. We don't use radio frequency ablation anymore because it doesn't last, and often it doesn't work. So we use a different type of energy called plasma, and it's also radio frequency energy, but more powerful. Shot. All right, so the target is, you see the pedicle there. We want that pedicle just lateral to the pedicle, lateral and at the superior corner. You want to be on the bone, specifically the transverse process. And I feel the bone. It's the beauty of this technique. You can actually feel the bone. So you know where you're in the right spot. Dr. Berndes has our patient super comfortable. Shot.
We have a few questions.
Wow, already a few questions.
Yes, sir.
Impressive.
This first one coming from Alex on YouTube, saying, "Hi, Dr. Deuk, you are awesome."
Oh, thank you. You're very kind. Appreciate that.
My question is, can facet joint nerves radiate pain and inflammation to the legs or hands?
They do not go. So the question is, can facet joint pain and nerves radiate to the legs or hands? The answer is no, they cannot go that far. They do radiate pain. It's called referred pain. And they radiate pain to, if you're in the neck facets, to the shoulder, and sometimes the proximal arm, but never the hands. And then if you're in the lower back, the pain can radiate to the thigh, the hip area of the thigh, but not past the knee. So there's definitely radiating pain, but there are limitations. Okay, once again, I'm on the bone. We call that bone the transverse process. I'm right where the transverse process meets the superior articular process, which is the facet joint. And I am right here destroying the pain nerves with the Deuk plasma rhizotomy, which I pioneered in 2023, because I got tired of people coming back with the same pain over and over again. Facet pain, joint pain, and I realized there's definitely a better way to do this than RFA. So I patented this technology in the United States Trade and Patent Office, and now we have a patent on it, and a few more coming as well. So far everything's going well. I've done the first 3 through 1 incision. I'm going to try to get one more done. Hold on, don't shoot yet, and I will take another question in a moment. Shot. Okay, good. So you see we're heading towards the next one. I'll take another question.
Copy that. Coming from Renzi Benzi on YouTube. Asking, yeah, I love the name, Renzi Benzi. Asking, can facet joint pain cause muscle spasms and nerve stabbing pain?
Yes, 100%. Renzi Benzi?
Correct.
Yeah, you are correct. Facet joint pain definitely will cause muscle spasms over the facets. As a matter of fact, facet joint pain is probably the most common cause of paraspinal muscle spasms. Paraspinal muscle spasms are muscle spasms along your spine. When you feel your back or your neck tighten up, that's a muscle spasm. And the facets are the most common cause. As a matter of fact, facet joint pain, arthritis pain, is the most common cause of muscle spasms along your spine. All right. Perfect. 4 down. Now don't take a shot yet, because let's see, 1, 2, 3, 4. We got 5, 6, 7, 8. So we've done 4 with 1 incision. Don't take a shot yet. Do not take a shot. And the reason I'm telling him not to take a shot, we use what's called navigation, X-ray navigation. Let's see, I think we're still good. Don't take a shot. And if he takes another picture with the X-ray, then I lose my place. So I want to try to figure out where I put my next incision. You got it? Okay, good. And shot. Perfect. That's exactly what I want. So no, that's not where the incision is. That's where the next burn will be. So the incision will be a little bit lower. I'm going to give some more numbing medicine to the patient to numb up the skin. The numbing medicine, folks, people get confused about numbing medicine. It's for the skin, not for the facets, not for the discs. One more shot. All right, so we got 1, 2, 3, 4, 5, 6, 7, 8. So I need to be a little bit lower. We should be fine. These incisions I'm making are 4 millimeters. They're the size of a Band-Aid, we call Band-Aid incision. I'll show them to you later. But they're tiny, tiny incisions. And we do the whole surgery through these tiny little cuts, but they are incisions. And so, unlike a needle-based procedure, this is a surgical procedure. Shot? All right, not the right spot. I always check my x-ray picture, and I always feel with the probe. So there's a feeling component to this as well. That's really nice. So 1, 2, 3, 4. This would be the next one. Perfect. Nice job, Jordan. My x-ray technician, Jordan, is phenomenal. He's doing a really awesome job helping me to co-localize my probe with the pain nerves. All right, Henry, we'll take some more questions.
Copy that. This next question coming from Brad on YouTube.
Hold on, shot. 1, 2, 3, 4, 5. Yep. So I want to be a little more lateral. And go ahead, Henry.
Brad asking, does your practice offer spinal cord stimulators?
We do offer spinal cord stimulators at Deuk Spine, but we don't recommend them very often. The reason being is that spinal cord stimulators are not a fix, not a proper fix to a problem. They just try to cover up problems, and generally the problems they're covering up are fixable, especially today where spinal cord stimulators are over-prescribed, overutilized. All right, I'm gonna have to get a picture and shot. We believe at Deuk Spine, spinal cord stimulators are overprescribed and overutilized. They're inappropriately put in. Okay, they should be put in patients who have permanent nerve damage that is not fixable with another treatment that could actually cure the problem. And so we don't recommend spinal cord stimulators to the same frequency and degree that other pain management doctors recommend it, because we're capable now with our technology of curing pain naturally, not putting metal devices in the body. Unfortunately, most doctors are not capable of doing the same. So they recommend stimulators, which, by the way, are very profitable. Stimulators are the most profitable procedure pain management doctors can do. The most profitable. Not even close. If you're doing an epidural steroid injection, you may get $120 from the insurance company. You do a stimulator, you get I think it's like $45,000 now. So $110 versus $45,000. And what's happening, unfortunately, is these pain management practices are being bought up by venture capitalists who are then pushing the doctors to put in as many stimulators as they can into patients. So there's been this increase in the number of stimulators put in, dramatic increase over the years, and it's not helping patients any better. There's temporary relief, if anything, for those stimulators. They get temporary improvement, shot, but they don't get long-term improvement, and the stimulators start to fail. How's he doing? No. I'm talking about like a breathing and ventilatory oxygenation standpoint. I'm not having any issues. I'm landing perfectly in the target zone on each one of these. Yeah, I got one more to go. So, to answer your question, we do spinal cord stimulators at Deuk Spine, but I don't recommend them because they are not a fix. They're a cover-up, and the cover-up stops working after a little while. Usually after 6 months. And the reason the stimulators fail after 6 months is they end up, the leads migrate, they move. So you put these paddle leads, you put them let's just say T8, T9. And then after a few months, they move. They're no longer at T8, T9. They literally slide down your spine. Shot? Yeah, this is all really good position. Very happy with this. Let me just see. Almost done on this side. I'm right on the bone and I can feel it, which is where you want to be. The bone being the transverse process, right where it joins with the superior articular process. Any questions?
Yes, we have a couple more questions. This next one coming from Lanu on YouTube.
Hi Lanu, welcome.
Asking, is masks still required when entering the building? Just wondering if COVID is still active in Florida.
No, masks are not required to enter our building, but they are required, obviously, in surgery. Shot? So yeah, no. Is COVID still a problem? I think it is to a degree. Occasionally, some people get it, but it's, thank God, not as common as it used to be. It's pretty uncommon. This will be our last burn on this side.
We have another question coming from Alex once more on YouTube, saying, thank you, Dr. Deuk. I have another question regarding your disc repair procedure.
Yes.
If the cervical disc gets reherniated again and you have to go in again to clean up the herniation, is there a danger to the cervical disc because you enter through it multiple times, especially when the disc is very dehydrated and you barely go through it?
Shot. Not at all. There's no additional risk except for the typical risk of surgery with Deuk laser disc repair. As any surgery, you know, there are risks, of course. The good news is with the cervical Deuk laser disc repair, we've been performing it for 19 years almost now, 18 and a half, and we've never had a complication with the cervical Deuk laser disc repair. That said, you are correct. Some people do re-herniate, and our re-herniation rate is 1%, but we never have an issue going back a second time. We're done with the left side. We'll go to the right side next. We've made 2 incisions, so I was able to treat 4 facets with each incision. Shot? Keep the questions coming. I'm happy to answer them for you guys. Shot?
No current questions, so we do have a comment coming from a Kelly saying...
Before you give the comment.
Of course.
Before you give the comment, I need to have, Jordan, are you optimized for T1 and T2? It looks good to me. I just want to make sure you feel the fluoro is at the right angle. And maybe pull it, I guess you can leave where it is. I think we're centered, which is nice. You can see the spinous process is in the middle of the pedicles. Show the audience that real quick. Guys, he's going to show you the spinous process. Here, take a shot. And then show the pedicle. No, that's right there. Yes. And show the other side. Right there. Yeah, it's like little eyes. And then the nose is in the middle of the face. That's where you want it, so you know you're shooting straight on. Some people have scoliosis, so you have to turn the scope a little bit. But when you're doing this procedure, you always want to center the spinous process between the pedicles, okay? All right, shot. And then Henry, why don't you share with the audience the video. I'm going to do some more numbing on the right side before we make our incision. Henry, why don't you share with the audience the video showing how do facet joints like this cause pain?
Copy that.
back. We are just trying to get to the right T1 shot. And while we're doing this, Henry, now that you've shown them how the facet joint can cause pain,
Correct.
why don't you show them how we fix that pain in the facet joint?
Copy that.
Shot.
Disc injuries are a common cause of chronic back pain. Facet joint injury is a common cause of chronic back pain. The inflamed facet tear generates pain signals. The best treatment for facet joint pain is the Deuk plasma rhizotomy. Inflamed facet joint pain nerves are destroyed. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. You can see how we perform the Deuk plasma rhizotomy. And actually, that picture there shows you the exact perfect placement of the probe for T1. Okay, there's the tip. I just need to be on the bone. That's the only thing, and I think I am now. Shot. You actually have to feel the bone, the patient's transverse process bone. It's the posterior cortex, posterior medial superior cortex of the transverse process. It's a mouthful. All right, so hold on. And shot. That's good. And I've already done T2 while you guys were watching the video. Perfect. The nice thing is, a lot of times you can actually feel the pain nerve that you're going for. It's called the medial branch of the dorsal ramus. You can feel it get cut. If you've done this enough, like I have, you can feel it give way, and you know you got it. That's 2 down. So when I feel the pain nerve get cut, it's not at every facet. It's at maybe 1 out of 3. That's just an average. Shot. So that's too low. So this part of the surgery is called navigation, because I'm navigating to the proper location. Well, I skipped number 3. I'm going to go back and do it. I just felt the pain nerve right there. That was pretty cool. So that was T4.
We have another question.
Give me 1 second,
Not a problem.
and I'll take it. I'm just focused right now on what I'm doing. I want to get a little more medial. And then I'll take the question, okay? But just not right yet.
Copy that.
Shot. I'm trying to get back up to T3. I've got to be able to feel the back of the bone, which is very close. I'm feeling it now. Let's see if I'm at the right one. Shot. Yeah, nice. So I'm definitely at the proper level, and I'm on the right side. Let's see where that is. Hold on. Shot. So the more lateral. As you go more lateral, the bone comes posterior. Oh, you don't want to be too lateral. You want to be more medial, where the bones come together, where the transverse process joins the supraarticular process, right about there. That's where the pain nerve lives. And you want to be on the top end of that, which I'll show you the perfect spot. Let's take a look where we are here. Shot. That is the perfect spot. Okay, it's where the TP, and you know the X-ray only gives you a little bit of information, right? The X-ray gives you 2 dimensions. It doesn't give you 3 dimensions. So you have to really have a hell of a ability to do 3-dimensional visualization based on experience. I've done a lot of surgery of the spine, open surgery, and I know what it looks like in there. I know the landscape, so to speak, and I take that knowledge and I apply it to that 2-dimensional picture to create a 3-dimensional story of what I'm working on. I'm actually going to be able to do a few more on this side. I'll take the question. Shot.
Copy that. We have another question as well. First one coming from Victor on Facebook, asking, how does the Deuk plasma rhizotomy differ from the regular rhizotomy?
That is a great question, Victor. And the good news is we're actually going to produce a video that will show you the difference so that you don't have to tolerate my explanation, which probably won't be good enough, but I'll do my best. A typical radiofrequency ablation is done when the doctor sticks a needle through the skin down to this target area, and they just leave it there and they burn, and they hope the pain nerve happens to be where the tip of the needle is. Now they take an educated guess. They use X-ray guidance just like I do, but they leave it there and they don't move it. Okay? The problem is, what if the nerve isn't where they were hoping it was? What if it's over a few millimeters to the side? And that happens all the time. That's a problem. That's a huge problem. Because if the nerve isn't where you put the tip of that needle and leave the tip of the needle, then you're not going to get it. So what I do is I can move my wand around and I can burn every single place where that nerve could be, in theory. All right, we got just a few more to go. So let me just see. 1, 2, 3, 4, 5, 6, 7, 8. Okay, good. I'm going to take this out. I think we need a new tip. Pressure. New tip. Hold on. No, not yet. And shot. That's perfect, actually. Right there, Luis. Right there. Thank you. Knife. We got one more set of burns to go. So with my technique, number 1, I wand. I can wand around. What that means is, instead of just sticking a skinny little probe in one spot and praying and hoping the nerve is there, which is not there, by the way, and even if it was there, the nerve is the same diameter as the probe. And you're not going to kill that nerve. Pressure here. Because the probe can't really kill the nerve. It just cooks a small area, and it's cooking, barbecuing the tissue, but it is not big enough to actually cut through the nerve, the pain nerve. You want to cut through the pain nerve so it never grows back. Otherwise, the nerve is going to grow back if you don't cut through it. The RFA doesn't cut through the pain nerve. My procedure does. That's the biggest difference. We cut that pain nerve and it never comes back. All right, which means our treatment is permanent, and it is. People that get this done never come back as long as we get all the nerves. Now, I mean, if I don't, guess what? That's on me. It's my fault. It's technical error, right? It's the surgeon's error, not getting all the nerve on every level. But when you start doing multiple levels like this, then the risk of not getting one of the nerves goes up, right? Because you're doing so many. All right, so shot. Now remember, these nerves live in a three-dimensional world. I'm on the bone right now. So if the nerve happens to be just above the bone and I didn't get it, well, guess what? It's still there. So that's why I can move around three-dimensionally with my probe. You cannot do that with an RFA. You literally place the RFA probe in one spot and you burn, and that's it. And if you didn't get the nerve, you didn't get the nerve. So they fail more than 50% of the time, and the nerves always grow back even if they get it. Shot. Just going to go back up here and get this guy one more time for thoroughness sake. I got 2 minutes left, Dr. B. Thanks. Keep the questions coming. These are good questions. So we burn with more energy, 10 times more energy than an RFA, and I can move my wand around to make sure I get all the targets.
We have another question.
Yeah.
Coming from Alex, once more on YouTube. Saying, thank you, Dr. Deuk. Can a re-herniation of a disc be seen on the MRI after the DLDR procedure?
Yeah, so first of all, if you get the DLDR procedure and you have pain in your back or neck after the DLDR, it's not coming from where we did the DLDR. It doesn't matter what the MRI shows. Remember, our procedure does not make your MRI look normal. You're still going to see a herniated disc because we can't get 100% of the herniation out of there. And you only need 50% of the herniation to go away with the laser in order to get complete symptom relief, 50%. So all of our patients have between 50 to 90 at most percent elimination of the herniation, 50 to 90%, never 100%. And what I tell people is don't expect your MRI to look normal after our surgery, because it won't. If you want your MRI to look normal after surgery, you need to go to China, okay, where they're going to take your whole spine out and put another person's spine in. And then you'll be on immunosuppressive therapy the rest of your life because you just had a transplant done. And it would be the stupidest thing anybody could ever do. We don't make spines look normal with surgery. Surgery will never make your spine look normal. No surgery in the world does that, except taking a cadaver spine and putting it in yours. So our goal is not to make your herniations go away. Our goal is to get rid of your symptoms. So if you look at an MRI after a DLDR, you're still going to see a herniation. The key is you're not going to have symptoms from that herniation. 30 seconds. And I know that because we've done 2,150 of those DLDR surgeries, and we've never had a failure. Never, not once. In other words, we've never had a patient that didn't get relief of their pain from the disc. Now, this is very important. When people still have pain after a DLDR, it is not from the disc. It's from the facets or something else we haven't treated. And we see that in 25% of our patients. Very common problem. Shot. This is it. We're done. Last one.
We have one more question.
And this patient, just so you know, he traveled from New Jersey to come here to get his procedures done. Done.
Sit down, please. Thank you.
Let's show our audience. Well, can we clean up a little bit? Give me some irrigation. Give me some num-num or something. All right, let me show you guys the incisions. Can you guys see this?
Yes, we do.
So unlike an RFA, which is just a needle stick, we actually have incisions. And there's 4 of them. So we got to get, hey, don't move. Let's go.
We're just waking up now. You're all done. You're doing great. Just a little disconnected.
And if you have any more questions, I'll take them.
One question left coming from Ping on Facebook
Good
saying,
job, Luis.
can someone come back to Duke Spine for a discogram after the DLDR to make sure it's healed okay?
No, you don't want to do anything with the disc after the laser surgery, because by injecting dye, you're putting pressure inside the disc. You don't want to blow out what healing has been done. I would never recommend that. Like I said, we've never had a patient have the DLDR of a disc and did not get the pain from the disc to go away. That's the goal. Get rid of disc pain, which causes back pain. Get rid of leg symptoms from a pinched or irritated nerve. We have never, not once, 2,150 surgeries times 2.5 discs per surgery is about 6,000 discs that I fixed with laser. 6,000 discs. Not a single one has ever had continuing pain after the surgery and the healing time. So there's never been a failure. Never.
And that is it for questions.
Thanks for joining us. Have a wonderful day. We'll be back on Thursday.